This is Magda, and this is Pierre. Both of them are patients, and we're making sure they have a say in what goes on here at EMD Sirona. We call being patient-directed. But what does that mean exactly? Well, you may have heard the term patient-centric before. This describes designing a healthcare experience around the needs of patients. It makes sense, but is it enough? We don't think so. We're aiming to go one step further by being patient-directed. This means patients and those who care for them actually help to design those healthcare experiences themselves. But how does it really work, you're probably asking? Good question. It works like this. Take one of our most important jobs, the discovery and development of new medicines. How does Magda fit into this process? First of all, we listen. We speak to patients like Magda to get a better understanding of what it's like to live with the disease we are focused on. There are lots of ways we do this. And it's not just patients. We want to understand the communities around them too, their caregivers, and the patient organizations that support them. Next, we act. The insights from patients and caregivers guide us in making important decisions. Things like how to design studies that are convenient and reflect the needs of the patients, how technology can help make participation in clinical trials simpler, where we need to develop user-friendly packaging for medicines, and the best way to share important information with patients, caregivers, and patient organizations. What matters most to us is helping to make an impact. This means working towards medicines which are carefully studied for safety and efficacy, as well as technologies that have the potential to make a positive difference in patients' lives. By including patients at every step of the way, we have the best chance to get this right. To find out more, search Patient Directed on emdsirona.com.
Good morning, and hello again. I'm Molly Murray, President and CEO of the Autoimmune Association, and I'm pleased to moderate today's discussion to address COVID-19, long COVID, and autoimmunity. Since COVID-19 emerged, it's been a challenging experience for everyone, regardless of who you are. This raised particular questions for immunocompromised individuals and those living with autoimmune diseases and immune-mediated diseases, as they'd had to navigate through the pandemic with a compromised immune system. In our discussion, we'll explore where things stand today with COVID-19 and what we have learned since it entered our lives nearly 3 years ago. This includes the role that COVID-19 vaccines continue to play in combating the disease, as well as a discussion on the phenomenon often referred to as long COVID, and what we know and what we're learning about this condition. And finally, we will discuss the role that viruses more broadly play in autoimmunity. I'm thrilled to be joined today by two esteemed experts to help us unpack these complex topics. Here with us is Dr. Lena Leuning-Prack, Professor of Pathology and Laboratory Medicine with the Perelman School of Medicine at the University of Pennsylvania, and also a member of the Autoimmune Association Scientific Advisory Board. And Ovid Amate, the President and CEO of the patient advocacy organization known as SolveME. Welcome, Dr. Leuning-Prack and Ovid.
Thank you.
Yes,
Thank you. Pleasure to be here.
Great to have you here. That was a very brief introduction of both of you. So I will turn it over to each of you to further introduce yourselves, say a bit about the organizations you're with and the work that you do. Dr. Leuning-Prack, let's start with you.
Sure. Well, so hello, good morning, everyone, or whatever time of day you're in today. And thank you, Molly, and thank you to the Autoimmune Association for inviting me to participate in this panel. As Molly mentioned, I'm a professor of pathology and laboratory medicine. I work at the Perelman School of Medicine of the University of Pennsylvania in Philadelphia. My area of research focus is on human lymphocyte biology in health and disease, and in particular in autoimmune disease. So I run a research lab, but I also help direct the clinical immunology lab at the hospital of the University of Pennsylvania, where we perform testing to diagnose and monitor patients with autoimmune disease.
Great. Thank you for that introduction. Ovid, can you share a bit about yourself, the organization you're with, and the work you do?
Yes, thank you very much for the invitation, and really a pleasure to be here with you today. My name is Ovid Amitai, and I'm a pharmacologist by training. Became a drug developer by trade, spent the majority of my professional career developing therapies for people with rare genetic diseases. and became an advocate by choice, so to speak. My sister has been battling myalgic encephalomyelitis, and this was something that I wanted to do something about. And so I joined Solve ME, which is an organization that's been around for about 35 years now. And my goal was to help identify diagnostics and treatments for this disease, which really currently we don't have any of that. And I made this transition at the beginning of the global pandemic, which is not something I would recommend doing. Switching to one area during a global pandemic that's not a great idea. But really, I think what happened was that the result of that, and we'll talk more about it, I think our community got closer to other communities, such as the autoimmune community. And I think that if there is some silver lining in that, I think is that we're broadening our understanding and our connections. And so I'm delighted to be with you today.
Delighted to have you here. And yes, we'll get into a little bit more about COVID, long COVID, and the work that we've been doing together. Thank you both for being here again today. Let's dive into the discussion. The first topic we're going to touch upon is COVID-19 vaccinations and where things stand today. And I will say before we get into discussion that for anyone tuning in today, any vaccine discussion decision should be made between you, the patient, and your physician. But with that being said, many questions have arisen in the autoimmune community, particularly early on in the pandemic on the topic of COVID-19 vaccines and whether or not there were special considerations that need to be made before getting vaccinated. So my first question is for you, Dr. Lunick-Pratt. Could you share a bit about some of the research and studies we have on vaccination and autoimmune disease, and particularly comment on COVID vaccine safety?
Yes, so thank you for that question. There are many important studies that have been carried out to evaluate vaccine safety, especially in the pandemic. There's just massive amounts of research going on. So with respect to vaccine safety, most studies suggest that the risk of receiving a vaccine, including the SARS-CoV-2 vaccines, is substantially lower than the risk of having disease from the virus infection. And that includes the risk of having autoimmune disease flares. So, for example, a large studies carried out at Cedars-Sinai Medical Center revealed that frequencies of adverse events, such as flares in autoimmune disease, or other adverse events, were similar in vaccinated patients with systemic autoimmune disease and in the general population. In some of our unpublished work, we've looked at vaccinated healthy individuals, and we see no evidence for increased autoantibody production in response to the SARS-CoV-2 mRNA vaccines. And this is in sharp contrast to people who have severe viral infection. Now, that again is a little bit of an unfair comparison, right? Because we're looking at severe viral disease versus most people who often do quite well with the viral disease, especially in our current era where a lot of people are protected by vaccination. But still, early in the pandemic, we were looking in individuals who had severe COVID, and there we and others have shown that those individuals actually have a substantial frequency of autoantibody and anti-cytokine antibody production. And this, again, these are in hospitalized patients with COVID, with actual infection, not with vaccination. So in this work that we did with PJ Utz from Stanford University and Krisanti Shivaki from the University of Marburg, we observed IgG autoantibodies and anti-cytokine antibodies in almost half of the hospitalized patients. So that's very different from vaccination, where that's not what we see, and where in most people, there's really very low levels of adverse side effects. However, again, I'd be remiss not to emphasize that the risk of severe disease, including autoimmune flare-ups following SARS-CoV-2 infection and or vaccination, may be changing as a higher fraction of the population is both vaccinated and the virus continues to evolve. So we don't, as of yet, know in our current time of all these different Omicron variants, how much of a risk benefit there is to receiving continued vaccines and how that will change over time.
That's very helpful. And I that kind of leads into a secondary question. You touched on vaccine safety. How about the efficacy?
Yeah, and I think that's a very important question, especially for patients with autoimmune diseases, where really the main challenge here is that patients with autoimmune disease often, with those who have severe autoimmune diseases can require significant immunosuppression. And such patients are less likely to respond well to any vaccine, including a SARS-CoV-2 vaccine. So in general, antibody responses, for example, to vaccines are lower in patients with autoimmune disease. And this effect people looked at this in multiple studies, but one particularly good one came out of Washington University School of Medicine in St. Louis, and where they really showed that the main issue was more the immunosuppression than the underlying autoimmune disease. And based on these types of large, population level studies and similar studies, the American College of Rheumatology has actually recommended delaying certain medications at the time of receiving a vaccine dose or booster. And this is specifically for individuals receiving certain kinds of immunosuppression, for example, methotrexate, Janus kinase inhibitors, or cyclophosphamide. But again, I want to point out what I think you said in the beginning, Molly, which is that the decision to withhold your immunosuppression or to modify the dosing or to change the schedule in some way, you really need to work that out with your physician. It should be a very, a very intensive discussion between you and your physician, because each person has, different things to consider. And these medicines, these immunosuppressive medicines, are of course very important for controlling the autoimmune disease. So it's a bit of a tightrope that you have to walk between balancing the level of immunosuppression and the level of immune activation that you need to achieve protection from the vaccine. And another factor that may influence the quality of the immune response, especially in immunocompromised patients, is the timing of the dosing. And so it may be that in people who are on significant immunosuppression, that you may need to stagger the dosing in a different way from healthy individuals, because it may take their immune system longer to generate a good response. And then the other thing I'll comment on here just quickly is that some people with autoimmune diseases are on B-cell depletion therapy. So for example, patients with multiple sclerosis, some patients with a blistering skin disorder called pemphigus vulgaris, and they receive therapies that eliminate a large fraction of their B cells. And we've been studying some of these patients, and actually by we, I really mean Amit Bar-Or and Amy Payne here at the University of Pennsylvania, when we've been looking at MS patients receiving B-cell depletion therapy. And as you would predict, they make very low levels of antibodies to the vaccine. But the amazing thing is that they make very substantial T-cell responses that are actually comparable and in some cases even exceed the responses in healthy individuals. So that's kind of interesting. Somebody with very low B-cell levels, these vaccines, and here we're really focused on the mRNA vaccines for SARS-CoV-2, they still confer some protection in the form of T-cell immunity. So that's, I think, something worth considering. It's even if you're B-cell depleted, you may have some protection from these vaccines.
Very helpful information for the audience that's listening here today. Ove, would you like to comment as well on COVID vaccine safety and efficacy?
Yeah, I would just add that, and we'll get into what long COVID is in a moment, but obviously we're very focused on preventing mortality and hospitalization. And of course, we know that that's where the COVID-19 vaccines are very, very effective in. But I think the part that most people don't really talk about that much is that vaccines are really the only way right now that we know how to prevent long COVID, which is really the longer term implications of the COVID-19 infection. And so right now we know that about 50% reduction in the risk to get long COVID is what we get from vaccines. And that's very, very important. And there was just a recent study last week looking at people with rheumatoid arthritis. And even in that population, in treated patients, we see the same reduction in long COVID. So I would just add that on the efficacy side, this is really very important, and something that, in my mind, I think also needs to be factored into this risk-benefit analysis that every patient needs to do with their healthcare provider.
Great. I do have a follow-up question with long COVID. Has there been any evidence to suggest that the more you get vaccinated, beyond the initial 2 doses, that you're less likely to develop long COVID, or do we know anything about that?
There's really not enough data on that. We do know that multiple infections do increase the risk for long COVID. So that is something that is known, and I think that we'll probably talk about it in a moment. This is one of the probably the ways to explain how conditions like myalgic encephalomyelitis or chronic fatigue syndrome and now long COVID, how they're developed. There are multiple insults to the immune system. So that we do know that multiple infections do increase the risk. So I think we can assume right now that if we prevent infection or reduce the risk for infection, this would also have a positive reduction on long COVID. But there's really no good data on that.
Okay, great. So we've started this discussion on long COVID, and but I'd like to dive in a little bit deeper. Can you tell us exactly what long COVID is? And then secondarily to that, what's your perspective on the long COVID landscape and our understanding of the disease? Because some researchers now consider it to be autoimmune related.
Yeah, so I'll try to give the exact definition, but I think it's actually really, it's a little hard because we all use the term long COVID sort of as an umbrella term. So I think people refer to long COVID as everything that happens after the acute infection is over. And for most people, if they're not hospitalized, the infection will be over between a week to 4 weeks. That's sort of the expected time of recovery. And so everything that really happens beyond that time is considered to be long COVID. I would probably try to make two distinctions. One is that there are certain things that happen as a result of the acute infection itself. In other words, if there is damage to the lungs, then they may be an ongoing lung disease or liver disease or kidney disease. But that in itself, really, in my mind, is not long COVID. Long COVID the manifestation is primarily fatigue. There's about 80% of people will complain about fatigue as the most disturbing symptom that they experience, and there will be pain, mostly headaches. They're all new. So I think for me, the definition is things are new to that individual, things that did not bother people before they had COVID, and they appear after the infection. So we mentioned fatigue, the headaches. There's definitely shortening of breath as a major symptom, and then there's what people refer to as brain fog, which is just a way of saying that there's a change in the cognitive function. And it could be impact on memory, it could be impact on the ability to concentrate, and ultimately the ability to carry daily activities. So these are really the most common symptoms that people refer to as long COVID.
Great. And then how about sort of second part of that? Is there a relationship to the long COVID and autoimmune disease? Is there any evidence of that?
So we don't really quite know the exact reasons for long COVID. Let's start with some of the explanations, and that will hopefully make the connection to autoimmunity. So it's clearly an immune response condition. And what triggers the immune response is either some kind of residual viral presence. So COVID-19 does have the ability to stay, as it turns out, in other parts of the body beyond what we can measure in the usual tests. So it could be in the brain, it could be in the gut. So maybe there is some kind of a response to a viral remnant. It could also be a reactivation of other viruses. And one of them, which we may talk about later, is the Epstein-Barr virus, which was known before to be a cause of autoimmune diseases. So that's another explanation. In one way or another, there's a dysregulation of the immune system. So it could be triggered by the viral presence, or it could be for other reasons that during the infection there's an imbalance of the immune response, and that really what triggers the long COVID condition. I think the evidence that we do see that more females are affected by long COVID than males, and so I think that's one of those connections that we've seen before in autoimmune diseases. So I think that does increase the likelihood that this is autoimmune. And I think that for the first time with COVID, we can see, as we heard before in some of the studies, that there's an abundance of autoantibodies that are being formed as a result of the acute COVID-19 infection. And so many of those symptoms could be explained by specific autoantibodies that are formed. So I think we'll begin to see the connection. But I think that long COVID in itself is probably going to be caused by either a combination of the factors that we just talked about, and it could be different factors in different people. So I don't think it's a single disease, but the autoimmune component I think will emerge as one of the key reasons.
Okay, great. That's helpful. Dr. Lundenprack, could you kind of piggyback on that and share a bit about some of the research, ongoing studies that you're aware of related to long COVID?
Sure. So first, I want to just comment on what Oved said and completely agree with him that it's very difficult actually to define long COVID, and that there are many different problems that people can have over different timescales and over different exposures to SARS-CoV-2 and other viruses that may be contributing to these wide range of phenotypes that we see. And it could be damage from severe viral infection, which I agree with Ovid that may well be something different, right? Especially the disability that may be associated with viral damage, but inability to clear the virus, generation of autoimmunity secondary to viral infection. And these are things that right now we have to try to figure out. So it's still somewhat early days for research in long COVID, but I do want to make people aware that there are several very large studies underway. Probably the earliest of these got started in the UK, where there are several very interesting clinical studies actually going on where they're looking at doing multiple organ scans, so radiologic studies, and then repurposing existing drugs to see if maybe those can treat patients who have certain types of abnormalities on their scan. So if patients have evidence of clots, for example, in their blood vessels, maybe then they could be receiving blood thinners. If patients have evidence of chronic inflammation, antihistamines are being considered. In the United States, the National Institutes of Health, or NIH, has launched a massive study to evaluate long COVID called RECOVER. And there are centers all over the country that are part of that study. So if you're interested in participating in that, and if you have long COVID or think you do, reach out. And you can even go online to the NIH website and find a local center. In parallel, the Centers for Disease Control in the United States have a study also on long COVID called INSPIRE. And again, there are many centers participating. And the broad goals of these programs are to understand, prevent, and treat long-term health effects associated with COVID-19, which of course is a massive umbrella for these types of studies. And their goals are to recruit massive numbers of patients who have different types of symptoms and presentations to try to understand the basis for the disorder and then also hopefully treat it. And there are a lot of different, they're looking both at all ages also. So even starting at gestational research and assessments, they're looking at what happens to children and mothers who have had COVID during their pregnancy. They're looking at multiple time points in individuals who either have long COVID or don't have long COVID, but have a similar kind of virus exposure, which will be very interesting to understand better why long COVID may be happening or what predisposes you to getting long COVID. There are cardiac imaging studies underway to look at the effects of COVID-19 on the hearts of patients with long COVID. There are observational studies of neurologic function after COVID. And again, this is what Ovid mentioned too. People often describe having brain fog or other symptoms related to the nervous system. So, and then on the pediatric side, there's several studies underway. One of them is to look in more detail at something called MISC, or multi-system inflammatory syndrome, which is a rare, but in some cases severe condition that some children who are infected with COVID can get. And there are other pediatric outcome studies underway as well. So it's really a massive global effort, I would say, and it's still early days in terms of the actual results because of the wide range of presentations, and just having to define what we're actually looking at is going to require these kinds of massive studies.
That's helpful. I know we've got about 5 minutes left, but I did want to have one quick follow-up question. That's maybe a longer discussion, but for somebody who thinks that they might have long COVID, and because this is so new and we're still researching it, where do they go for help? Or how do you get started with that?
Yeah, so maybe a couple of comments. One is that I think long COVID is new, but the idea that a long-term disease could be triggered by an infection, that's not new. And that's, our community with myalgic encephalomyelitis, chronic fatigue syndrome, really had known that for generations. And I think that one of the most important things to just share, and that's, before we even talk about treatment, is really how to prevent that. And one of the most important things that we've learned is that at the time of healing, really trying to make sure that we don't try to push ourselves, that the advice that many healthcare providers will give people who have COVID is just go back to normal as quickly as you can. Try to go back to exercising. And the reality is that healing is important more than anything else. And so sometimes trying to push ourselves really just exacerbates the situation. So for people who do have long COVID, it's very important to rest and try to get as much rest as possible. There are specific long COVID clinics now in most places, and I think that if people experience this fatigue, cognitive changes or dysfunction, and also the phenomena that's known as post-exertion malaise, which is that repeated exercise or some kind of mental exertion could also trigger that crash. These are really the symptoms that people should pay attention to, and very often we don't really think about it as long COVID. We think about COVID as something that has more to do with the respiratory system. People should just be aware of that. And so those long COVID clinics are probably the places to go to, and but really just make sure that people get the opportunity to rest as much as possible to expedite the healing process.
Great advice. And rest, don't push it. Sometimes people want to do the reverse, right?
Yeah.
Great advice. Okay, let's get into switch the topic a little bit. Should the discussion, the conversation surrounding COVID-19 and autoimmune diseases, it's opened up actually conversations around other viruses and autoimmunity. Could you share a bit more about some of these findings? And I'm thinking of Epstein-Barr virus, which we touched on a little bit earlier. But Dr. Luna-Crack, let's start with you and COVID or Ovid. I'd love to hear your thoughts as well.
Okay, let me just quickly say a few things. So Epstein-Barr virus, or EBV for short, is a herpes virus. It infects nearly everyone, and most infections occur early in life. Infections in adolescents and young adults can result in something called infectious mononucleosis, or mono for short. Although the cells initially infected by the virus are in your respiratory tract, and they eventually, B cells, my favorite cell, right, serve as the major reservoir for the virus throughout life. And EBV can actually reactivate in immunocompromised individuals, as well as during acute stress, including infections. So, of course, it has come up now that maybe there's evidence that could potentially link EBV to long COVID. And I'll let Ovid comment on that a little bit more. But I think it's still somewhat early days. Where we are starting to get somewhat more convincing evidence, actually, is in the area of MS. So normally it's very challenging, actually, to link EBV to autoimmune diseases because of the high frequency of infection, and because infections of any kind are actually often temporally correlated with disease flares. And temporal associations are not very strong evidence of causation, even though in our brains we're kind of hardwired to think that way, right? So whenever things happen close together in time, we often think that we want to try to attribute them to a common cause. However, in the case of MS, there's actually some pretty compelling recent data from military recruits where they looked at over 950 people who were diagnosed with MS during their military service and followed them out over time, and showed that in these individuals, the risk of MS was about 30-fold higher after infection with Epstein-Barr virus, but not higher after infection with other viruses that are similar, such as CMV or cytomegalovirus. And they also showed that there were markers of neuronal injury that came up and preceded the development of MS, but were, followed the EBV infection. And what's even more interesting is that a recent study showed that there was molecular similarity between one of the EBV proteins called EBNA1 and a protein that's found in the central nervous system called glial cell adhesion molecule. So this idea suggests that there may be some form of molecular mimicry between the virus protein and self proteins in the nervous system, and that in the process of responding to the virus, the immune system in individuals who are susceptible, which is only a small fraction of the overall population, but in susceptible individuals, that may result in an off-target effect on the central nervous system. And then again, the evidence linking EBV to long COVID, let me turn it over to my colleague, Ovid, because again, from where I sit, it's still early days, but he may have other insights.
Yeah, I think it's still early days, but I think it's becoming very clear that at least a subset of people with long COVID have a reactivation of EBV, and whether that's really the cause of the symptoms, I think that's starting to become more and more clear, and that's between 15% to 45%, depending on the study that you're looking at. So I think the role of EBV is quite clear, at least in some people. That will be a target, and of course, with better antivirals, this could be a very important target for a therapeutic approach. And I will just one other thing, which again, we're always looking for the silver lining in the COVID-19 story, and the emergence of the mRNA vaccines and the success of those vaccines is now leading some companies to develop mRNA vaccine for EBV. And so the idea that in a few years from now we'll be able to potentially prevent multiple sclerosis from happening by eliminating the risk of EBV, and maybe even for other infections or other consequences. I think to me that's an exciting thought, that we could really use those vaccines as a preventive way, very much like like we've used in other vaccines. And so I think that is also something that came out of COVID, which gives us some hope for better use of vaccines in the future.
Fantastic. Well, this has been a wonderful discussion, and I really want to thank you, Dr. Luning-Prack and Ovid, for sharing your time and your expertise with us today. I think the more we all understand and are more prepared for COVID-19 and on COVID, the better off we'll be. So thank you very much for your time, and take care.
Thank you very much. And Molly, maybe I'll just...
Thank you.
Thank you very much. I think we've included a link. We were able to have a public service announcement with a video that just helps to describe what long COVID is, and I think you were very generous to put that in the packet, so people may want to watch this video if they haven't seen that on their local TV channel, and hopefully that will increase the awareness for long COVID and the empathy for people who are struggling with it. And of course, will generate more research and hopefully the treatments and the cures that we're looking for. So thank you for the opportunity to share that.
We'll get it posted, certainly in our community board. So thank you for the reminder for that, and definitely check it out.
Thank you very much. Pleasure to be with you today.
Pleasure to be with you as well. Take care. Bye-bye.